Hello, ladies and gentlemen. This is Jeyasurya from Tagore Medical College with an amazing topic, the hand. These are the anatomical aspects of hand that I'm going to cover in this video. The osteology of the hand, skin, flexor retinaculum, carpal tunnel, palmar aponeurosis, depetrance contracture, ulnar and radial bursae, the muscles of the hand. Moving on with the osteology of the hand, these are the carpal bones of the hand, these are the metacarpal bones of the hand, and these are the phalanges of the hand. So basically the carpal bones are the scaphoid, lunate, triquetrum, pisiform, and the trapezium, trapezoid, capitate, and hamate. So moving from lateral to medial aspect, this is the scaphoid and lunate, triquetrum, and pisiform. This is the trapezium, trapezoid, capitate, and hamate. Now, how to identify these bones when given separately? Scaphoid, the scaphoid bone is boat shaped and has a tubercle on its lateral side. The lunate is also called as crescent or the half moon shaped bone. The triquetral bone is pyramidal in shape and has an isolated oval facet on the distal part of the palmar surface. And the pisiform bone, as you could see in this picture, it is P-shaped and has only one oval facet on the proximal part of the dorsal surface. Now moving on to the distal row of bones, that is the trapezium, trapezoid, capitate, and hamate. The trapezium is quadrangular in shape and has a crest and a groove anteriorly with its concave convex articular surface distally. And next to that lies the trapezoid bone, which looks alike the shoe of a baby. Now moving on to the capitate bone, being the largest carpal bone, it has a rounded head, and next to that lies the hamate, a wedge-shaped bone with a hook near its base. Now directly moving on to the integumentary system, the skin of the palm. Basically, this is the palmar aspect of the hand, and this is the dorsal aspect of the hand. The skin of the palm, being an immobile tactile organ, protects the underlying tissues and produces definitive grip with the multiple palmar creases and the underlying superficial and deep fascia. So basically these are the palmar creases that you could see, and this is the wrist crease that lies on the palmar aspect for the gripness. This deep fascia next to the superficial fascia beneath the skin is connected with the skin with the help of the superficial fascia, and this deep fascia is specialized to form the flexor retinaculum in the wrist, palmar aponeurosis in the palm, and fibrous flexor sheaths in the fingers. Moving on to the flexor retinaculum. This flexor retinaculum is a thick connective tissue which forms the roof of the carpal tunnel. It spans between the hook of the hamate and pisiform bone medially, and scaphoid and the trapezium bone laterally. This is the lateral aspect of the palm, and this is the medial aspect of the palm. And this is the flexor retinaculum, which is spanning between the medial and lateral carpal borders. That is the bones. Now moving on to the carpal tunnel, the flexor retinaculum, being a strong fibrous band, bridges the anterior concavity of the carpus or the carpal bones and converts it into a tunnel, the so-called carpal tunnel. This is the carpal tunnel that you could see in the picture, and this is the flexor retinaculum, which spans medially to laterally and bridges the carpal bones. On the other hand, this flexor retinaculum provides a lateral deep slip and a medial superficial slip or the volar carpal ligament. The flexor retinaculum, also called as the transverse carpal ligament, giving the lateral slip. This is the lateral deep slip which is attached to the medial lip of the groove on the trapezium, which is thus converted into a tunnel for the tendon of flexor carpi radialis. So this is the flexor carpi radialis tendon. Now the medial superficial slip or the volar carpal ligament, it is attached to the pisiform bone, whereas the ulnar vessels and the nerves pass deep to this slip. Now the structures passing superficial to the flexor retinaculum, these are the structures passing superficial to the flexor retinaculum are the palmar cutaneous branch of the median nerve. This is the palmar cutaneous branch of the median nerve. The palmaris longus tendon, the palmaris cutaneous branch of the ulnar nerve, and the ulnar vessels, the thenar and the hypothenar muscles. These are the thenar muscles, and these are the hypothenar group of muscles. These are the hypothenar group of muscles, and these are the thenar group of muscles. Now the structures passing deep to the flexor retinaculum are the median nerve. Here you could see the median nerve, whereas the palmar cutaneous branch of the median nerve doesn't pass through this flexor retinaculum or the carpal tunnel, and it passes above the flexor retinaculum. So basically the median nerve, the 4 tendons of the flexor digitorum superficialis, these are the tendons of the flexor digitorum superficialis, and the 4 tendons of the flexor digitorum profundus, along with the tendon of the flexor pollicis longus, the radial bursa, this is the radial bursa covering the flexor pollicis longus tendon, and the ulnar bursa being common to both the flexor digitorum superficialis tendons and the flexor digitorum profundus tendons. Now the tendon of the flexor carpi radialis lies between the flexor retinaculum and its deep slip in the groove on the trapezium. Moving on to the palmar aponeurosis. The palmar aponeurosis is a triangular shape. This is the palmar aponeurosis. Look at the picture. As you could see, this is triangular in shape in the cadaveric image. This is the triangular palmar aponeurosis, where the apex is lying proximal and blends with the flexor retinaculum. It's blending with the flexor retinaculum, and it is continuous with the tendon of the palmaris longus, whereas the base is directed distally, and it is divided into superficial and deep strata, where the superficial strata is attached to the dermis, and the deep strata divides into 4 slips opposite to the heads of the metacarpal bones. These are the metacarpal bones, which are not clear in this image, which are lying deep, whereas the deep strata gets attached to the heads of the metacarpals of the medial 4 digits. Each slip divides into 2 parts. As you could see, the divided parts, which are continuous with the fibrous flexor sheaths, and the extensions pass to the deep transverse metacarpal ligament, the capsule of the 𝗵𝗶𝗴𝗂𝐴𝐺𝐸𝐴L joints, and the sides of the base of the proximal phalanx. The digital vessels and nerves and the tendons of the lumbricals emerge through these intervals. As you could see in the picture, these are the emerging tendons of the lumbricals. From the lateral to medial margin of the palmar aponeurosis, the lateral and medial palmar septa passes backward and divide the palm into compartments. As the basic function of this palmar aponeurosis is to fix the skin to the palm, and thus improving the grip for its manipulation of the hand. Now moving on to the fibrous flexor sheaths of the fingers. These are the fibrous flexor sheaths of the fingers, as you could see in the picture. The fascia that is thickened and arched along the sides of the phalanges and across the base of the distal phalanx, whereas proximally it is continuous with the slip of the palmar aponeurosis. In this way, a blind osteophacial tunnel is formed, which contains the long flexor tendons enclosed in the digital synovial sheath. The fibrous sheath is thick opposite the phalanges, as you could see in the image, and thin opposite the joints to permit the flexion of the fingers. The sheath holds the tendon in position during the flexion of the digits, as you could see the flexion of the digits in the cadaveric image. Now moving on to something like the 𝗵𝒐𝒃 contracture. What is 𝗵𝒃 contracture? It is a clinical condition due to the inflammation involving the ulnar side or the medial aspect of the palmar aponeurosis, where there is thickening and contraction of the aponeurosis. As a result, the proximal phalanx and later the middle phalanx become flexed and cannot be straightened, whereas the terminal or the distal phalanx remains unaffected. The ring finger is the most commonly involved in the 𝗵𝒕𝒻's contracture, as you could see in the image, where there is the flexion of the proximal and the middle phalanx, whereas the distal phalanx is unaffected. Now moving on to the synovial sheath of the long tendons, which is composed of the synovial fluid, which functions to mainly lubricate the tendons for its fine movements. Primarily, the radial bursa is encloses the tendon of the flexor pollicis longus, whereas it extends proximally from the forearm and distally into the digital synovial sheath of the thumb. This is the radial bursa, as you could see in the picture. It extends until the synovial sheath of the thumb, whereas the ulnar bursa encloses the flexor digitorum superficialis and the flexor digitorum profundus tendons, where it extends proximally from the forearm and distally into the end and along the little finger. Distal medially it extends as the digital synovial sheath. Now these bursae are usually separated and may be continuous deep to the flexor retinaculum. Now the digital synovial sheath encloses the flexor tendon of the digits, extends same as the fibrous flexor sheaths along the head of the metacarpal to the lower part of the distal phalanges. Here you could see clearly the digital synovial sheaths, whereas the synovial sheaths of the long flexor tendons, also composing the synovial fluid, functions for the free movement of the tendons to minimize the friction beneath the underlying structures. Now moving on to the musculature of the hand. Basically, there is two kind of muscles. There is the intrinsic group of muscles and the extrinsic group of muscles. Today we are going to focus on the intrinsic group of muscles. Starting with the intrinsic group of muscles, they are located within the hand itself. They are responsible for the fine motor functions of the hand. Starting with the thenar muscles, these are the three short muscles located at the base of the thumb. The muscle bellies produce a bulge known as the thenar eminence. They are responsible for the fine movements of the thumb. Here you could see this is the thenar eminence, as you could see in the cadaveric image. For the convenience of the remembrance of the thenar muscles, let's make a mnemonic of FAO, where F represents the flexor pollicis brevis muscle, A represents the abductor pollicis brevis muscle, and O represents the appenens pollicis muscle. Whereas starting with the appenens pollicis muscle, being the largest of the thenar muscles, lies underneath the other two muscles, that is the flexor pollicis brevis muscle and the abductor pollicis brevis muscle. It originates from the tubercle of the trapezium along the lateral aspect. Somewhere here lies the tubercle of the trapezium. Trapezium, and it is associated with the flexor retinaculum, and it inserts into the lateral margin of the metacarpal of the thumb, that is the first metacarpal bone. It acts to oppose the thumb by medially rotating and flexing the metacarpal on the trapezium. It is innervated by the median nerve. Now moving on to the abductor pollicis brevis muscle. This muscle is found anteriorly to the appenens pollicis and proximal to the flexor pollicis brevis muscle. It originates from the tubercle of the scaphoid and trapezium and form the associated flexor retinaculum, and from the associated flexor retinaculum it attaches to the lateral side of the proximal phalanx of the thumb along these aspect, and it also acts to abduct the thumb as the name goes. Now moving on to the flexor pollicis brevis muscle, the most distal of the thenar muscles. It originates from the tubercle of the trapezium, somewhere here, and from the associated flexor retinaculum, it gets attached to the base of the proximal phalanx of the thumb. It acts to flex the metacarpophalangeal joint of the thumb. It is also innervated by the median nerve, that is the deep head is innervated by the deep branch of the ulnar nerve as an exception, whereas all the other muscles are innervated by the median nerve. Now moving on to the hypothenar muscles. Unlike the thenar muscles, the mnemonic here also goes like the FAO, the flexor digiti minimi, the abductor digiti minimi, and the opponent's digiti minimi. The hypothenar muscles produce something called as the hypothenar eminence, nothing but a muscular protrusion on the medial side of the palm at the base of the little fingers. The ulnar nerve innervates the muscles of the hypothenar eminence. As the mnemonic goes, the FAO, let's start with the O, the opponent's digiti minimi. The opponent's digiti minimi lies deep to the other hypothenar muscles, and it originates from the hook of the hamate and is associated with the flexor retinaculum and gets inserted into the medial margin of the metacarpal bone, that is the fifth metacarpal bone, whereas here lies somewhere the opponent's digiti minimi muscle. It is innervated by the ulnar nerve and it acts to rotate the metacarpal of the little finger towards the palm during producing a position. Now next to that is the abductor digiti minimi muscle. The most superficial of the hypothenar muscles originates from the pisiform and the tendon of the flexor carpi ulnaris. It attaches to the base of the proximal phalanx of the little finger and it abducts the little finger. It is also innervated by the ulnar nerve. So now the abductor digiti minimi is around somewhere here, gets inserted into the proximal phalanx. Now moving on to the flexor digiti minimi brevis muscle. The muscle lies laterally to the abductor digiti minimi and it originates from the hook of the hamate and the adjacent flexor retinaculum and gets inserted into the base of the proximal phalanx of the little finger. So the flexor digiti minimi brevis lies somewhere around here, quite laterally, and it flexes the metacarpophalangeal joint of the little finger and it is also innervated by the ulnar nerve. Along with the thenar and the hypothenar muscles, there are a small extension of the muscles, the abductor pollicis and the palmaris brevis respectively. Now moving on to the lumbricals. These are the 4 lumbricals in the hand that you could see, with each associated with each finger. They are very crucial to finger movement, linking the extensor tendons of the flexor tendons. Now the denervation of these muscles is the basis of the loss of the benediction, that is ulnar claw hand seen, whereas these muscles, each lumbricals originate from the tendon of the flexor digitorum profundus. This is the tendon of the flexor digitorum profundus, and they pass dorsally and laterally around each finger and gets inserted into the extensor hood. These are the lumbrical muscles. These are the tendons of flexor digitorum profundus, whereas these tendons gets inserted into the distal phalanx along the palmar aspect, whereas the lumbricals gets inserted into the extensor hood of the fingers. They act to flex at the metacarpophalangeal joint and extension at the interphalangeal joints of each digit, and their innervation goes like this. Whereas the lateral 2 lumbricals, that is of the index and the middle fingers, these 2 lumbricals are innervated by the median nerve, and the medial 2 lumbricals of the little and the ring finger is innervated by the ulnar nerve. Now moving on to the intraochian muscles. The intraochian muscles are located between the metacarpals. They can be divided into two groups, the dorsal and the palmar interossei. The dorsal interossei, being the most superficial of the all dorsal muscles, these can be palpated on the dorsum on the hand. There are 4 dorsal interossei muscles. Each interossei originates from the lateral and medial surfaces of the metacarpals. They attach into the extensor hood of the proximal phalanx of each finger. So basically these are the dorsal interossei that you could see in the picture, and they act to abduct the fingers of the 𝗵𝒵𝒴𝗂𝗀𝒃 joint and are innervated by the ulnar nerve. So basically, as the mnemonic goes, like 𝐷𝒓𝒄𝗏, where D represents the dorsal interossei and 𝒂𝒃 represents the abduction of the fingers. Now moving on to the palmar interossei, these are located anteriorly on the hand. There are 3 palmar interossei muscles, although some textbooks represent 4 palmar interossei muscles, whereas these interossei muscles, that is the palmar interossei, originate from the medial or the lateral surface of the metacarpal bones and gets attached into the extensor hood of the proximal phalanx of the same finger. As you could see in the picture, they adduct the fingers at the 𝗵𝒵𝒴𝗂𝗀𝒃 joints and are innervated by the ulnar nerve. Now moving on to the clinical aspects of the hand, something called as the ulnar claw hand and the carpal tunnel syndrome. First of all, the ulnar claw hand, it is due to the lesion of the ulnar nerve, which is characterized by the hyperextension at the 𝗵𝒵𝒴𝗂𝗃 joints and the flexion at the interphalangeal joints. As you could see in the image, there is the flexion at the interphalangeal joints and hyperextension at the 𝗵𝒵𝒴𝗂𝗃 joints, involving the ring and the little finger more than the index and the middle finger. The little finger is held in extension by the extensor muscles, whereas the intermetacarpal spaces are hollowed out due to the wasting of the interosseous muscles. The claw hand deformity is more obvious in wrist lesions as profundus muscle is bad. This is something called as the action of paradox, where there is marked flexion of the terminal phalanges. Now moving on to the carpal tunnel syndrome, which is the important clinical correlation of the carpal tunnel. Compression of the median nerve within the carpal tunnel causes something called as the carpal tunnel syndrome, which is the most common mononeuropathy and can be caused by the thickening of the ligaments and the tendon sheaths. However, it is idiopathic. If the carpal tunnel syndrome is left untreated, it can cause weakness and atrophy of the thenar muscles. And I hope that's a wrap. Thank you.